Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching video class. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. So today in this episode, I am going to discuss one more image-based question in lower GI tract pathology. So our patient is a 26-year-old man presented 5 years ago with loose stools, bright red blood rectal bleeding and passage of mucus for few months duration. He underwent a major bowel operation where the whole large bowel was removed and he had a temporary stoma in the right iliac fossa, most probably ileostomy, for 3 months, which was subsequently closed. He is well and is on regular annual follow-up since his operation at the age of 21 years. His father died at the age of 38 years from bowel cancer. So this is the case scenario, and these are the 2 pictures, and these are the 7 questions. So question number 1, what is the investigation in figure A and the findings? Question number 2, what is there in figure B here and the findings? Question number 3, with this clinical picture and the findings in figure A and in figure B, what is your most probable diagnosis and why you are saying so? Question number 4, describe the hereditary nature of this condition. Question number 5, what other tumors are associated with this condition? Question number 6, how do you keep a family under surveillance? Question number 7, once diagnosed, what is your definitive management? So I request my viewers to pause the video and try to answer all these 7 questions. After answering, you can verify your answer with the correct answers, which I am going to discuss in the subsequent slides. So question number 1, what is the investigation in figure A and its findings? The correct answer is, this is a colonoscopic picture. This is a colonoscopy. It is showing the whole colon is studded with numerous polyps. You can see innumerable polyps there. Everywhere you are seeing only polyps. This is the finding in this figure A. Question number 2, what is there in figure B and its finding? This one. So the correct answer is, figure B is showing the resected specimen of the whole large intestine up to the anus, and this surgical procedure is called total proctocolectomy specimen. So they are removing the whole colon, including the rectum and anal canal. It is showing clearly numerous polyps throughout the large intestine. You can see the whole large bowel. They have cut open the colon, the whole colon, rectum and anal canal. You can see plenty of small polyps are there. So it is showing clearly numerous polyps throughout the large intestine. If there are more than 100 polyps covering the colonic mucosa, it is familial adenomatous polyposis. If there are fewer than 100 polyps, it is called attenuated familial adenomatous polyposis. These adenomas in FAP or familial adenomatous polyposis are usually 1 to 3 millimeters in size, and these are smooth surface with regular border, and the mucosal color is the normal pink color. The question number 3, with this clinical picture and the findings in figure A and figure B, what is your most probable diagnosis and why you are saying so? The correct answer is, with this clinical picture along with the colonoscopic features and the resected specimen features, the diagnosis is FAP, that is familial adenomatous polyp. He is a young man with strong family history of colonic cancer because his father died at the age of 38 years old because of the colonic cancer. Patient presented with bright red blood per rectum or hematochezia, loose stools, and he is also passing mucus. Colonoscopy revealed innumerable polyps all over the colon, and he underwent total proctocolectomy, and he is under regular annual follow-up. Question number 4. Describe the hereditary nature of this condition. The correct answer is FAP is an autosomal dominant inherited disorder characterized by adenomatous polyp distributed throughout the GI tract, predominantly in colon and rectum. One would suspect FAP when greater than 100 polyps are found in colon and rectum. There is a mutation of APC gene located on chromosome SQ2122. This is the APC gene mutation in the chromosome SQ2122. The polyps usually begin to appear at puberty, and by the age 20 to 35 years, symptoms such as rectal bleeding, change in bowel habit, and abdominal pain are present. In this condition, there is 100% chance of developing colorectal cancer if the colon is left in situ. 5. What other tumors are associated with this condition? The correct answer is, early in life, in 2/3 of these patients, there is what is called congenital hypertrophy of retinal pigment epithelium, or CHRPE. Yeah, this is 97% sensitivity. If somebody is having during very early childhood congenital hypertrophy of retinal pigment epithelium, you have to suspect familial adenomatous polyp and you have to do the genetic testing. And the other tumors associated with this FAP is Gardner syndrome. This is FAP plus patient also will have sebaceous cyst, osteoma, and desmoid tumor in the mesentery. Turcot syndrome, whereas in Turcot syndrome there is FAP plus the CNS tumor, especially the childhood cerebellar medulloblastoma. Question number 6. How do you keep a family under surveillance or follow-up? The correct answer is, as this is an autosomal dominant disorder, there is a 50% chance of the first degree relative carrying the abnormal gene. Direct genetic testing to identify mutation in chromosome 5q2122 is available. The family is kept under surveillance by offering the offspring annual colonoscopy from the age of puberty, and genetic testing for this APC gene mutation also can be performed. If the abnormal gene is present, then you must do prophylactic colectomy in these patients. Otherwise, these patients are definitely going to develop the FAP and then subsequently colorectal cancer. So you have to do what is called prophylactic total colectomy. Question number 7. Once diagnosed, what is your definitive management? The correct answer is, the definitive management is either you can do colectomy with ileorectal anastomosis, often followed at a later age by proctectomy with ileoanal pouch procedure, or an initial primary proctocolectomy with ileoanal pouch procedure straight away with covering loop ileostomy. So this is what you can do. If you are doing colectomy with ileorectal anastomosis, preserving the anorectal function, it is a safe operation with minimal complication, and the functional results are better because there is no pelvic dissection. In these patients, however, there is a reported incidence of rectal cancer in 30% of these patients after 20 years. The operation of proctocolectomy with ileoanal pouch removes all the colorectal mucosa prone to cancer and avoids a permanent stoma also. So thank you very much for watching this video. If you think that these videos are very helpful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notification regarding my latest upload. Thank you once again for watching this video. Let us meet in yet another video. Until then, bye bye.